Hi, everybody. My name is Anne Marie Hughes, and I am a 10-year pancreatic cancer survivor. Thanks a lot to my guest here today, Dr. Charles Yeo. Hi, Dr. Yeo.
Hello, Anne Marie. Great to see you. I can't believe it's been a decade.
I can't either, but you told me I would be here. I don't think I quite believed you then.
Well, it's very gratifying to see someone doing well 10 years out from pancreas surgery. Remember, Anne Marie, there are many people in America don't even know the pancreas exists. So there's an education gap, and I've been the beneficiary not only of surgery, but other treatments that have helped you along the way. So truth be told, it's just not been the surgeon's scalpel.
That's true. And one of the benefits that we have here in Philadelphia is that our doctors all work together, no matter what the institution they're at. When I first met you, you handed me your card proudly, which had a picture of a pancreas on the back of your card. Tell us how you came to be a pancreatic cancer surgeon.
I did not go to medical school with the intent of becoming a pancreatic cancer surgeon. Through medical school, I initially thought I wanted to be a medical doctor, an internist, but I was convinced otherwise by mentors, very, very wonderful people in surgery. Dr. John Cameron at Johns Hopkins, Anthony Mbembo, Mike Zinner, many others. And I was attracted to the field of surgery. There wasn't much pancreatic surgery being done at the time. I'd say there are two important things that happened in my life. Number one, I was offered the opportunity to get what's called a clinician scientist award. Part of that clinician scientist award, I got to see something called the NIH guide. Around 1989 or so, it said the NIH had a bucket of money. They realized that pancreatic cancer was sort of a poor stepchild, that it hadn't had much research done on it. So they wanted to give people money to study pancreatic cancer. So I saw that. I pulled together a group of people that are way smarter than me, including Ralph Ruban and Elizabeth Jaffe and others. And we wrote an NIH grant, and it got the best score in the country. The grant was called Correlates and Treatment of Pancreatic Cancer. It was funded in about 1990, 1991. It was for several $1 million. And we were able to put the genetics of pancreatic cancer on the map. And part of that came with the work that John Cameron, who I'd have to say is my most important mentor, was at that point just really starting to build a very large practice of surgeons operating on patients with pancreatic tumors. So it's that convergence that led me to focus more attention in pancreas domains. It's been a great career for the last now over 3 decades. Given the opportunity to operate on thousands and thousands of patients with pancreatic tumors, I got a chance to train literally hundreds of medical students, dozens of fellows, residents, work with really smart faculty members. Plus, I get to work with my wife. My wife got her PhD in epidemiology of pancreatic cancer. And every week, my wife and I see patients together. We talk about pancreatic cancer. So I feel very, very fortunate. And I don't think I could have had a career that would be as satisfying to me. So
It's a grueling surgery.
You don't see many out of shape pancreatic surgeons, that's for sure. The gal I did yesterday, it was about a 10-hour operation. Some people, the surgery can take 3 or 4 hours. It's a challenging field, no question. Not a day goes by that I don't learn something new. And every day in the OR, Monday, Wednesday, Friday, we go to a locker room, we put on scrubs, we go and work with a team. And it's a competition. The competition is between the cancer and us. You know, can we safely remove the cancer and give the patient an opportunity for cure? And that keeps you going.
No early detection yet. What do you see on the horizon for that?
Think of the resources that were put in to COVID worldwide. And obviously, killing 5 million plus people thus far. So deservedly, resources were put there. As we continue to study pancreatic cancer, as the NIH and other funding mechanisms continue to fund, there will be a breakthrough. We've been looking for the magic blood test for pancreatic cancer for many years. There's excitement around circulating tumor DNA. There are problems with that technology. It's probably not going to be the holy grail. And as the tumor cells sort of live in a protective cocoon, if you will, I think we're probably a new technology away for screening the population. We have to recognize that there may not be a perfect blood test anytime real soon, but we'll eventually get there.
One of the things that people talk about is doing chemo and radiation ahead of surgery. Have you seen a lot of success with that approach, especially if the stroma exists and makes it difficult to break the barrier to that tumor?
We don't have the full answer to a surgery first approach versus what you're referring to, a neoadjuvant chemoradiation approach. And there's actually pros and cons to both sides. I think you have to recognize that for most patients, when pancreatic cancer is diagnosed, it's not early. There are things called circulating tumor DNA. The tumors can metastasize relatively early. And so there's an advantage for many people to get systemic therapy up front to treat the whole body, and then to diminish the risk of subsequent metastatic disease, and then to resect the tumor. But I don't think that's necessarily the best option for everyone. We do a survivor photo every year at our symposium, and it is, getting 100+ people together as survivors of pancreatic cancer. It's a wonderful feeling. There are many people in that audience who opted not to get chemotherapy, not to get radiation therapy, had their surgery up front, and are still alive 5, 10, 15 years later. So, it's not black or white, and you have to do what you think is correct, what's best for the patients. We still have more to learn. We need big randomized controlled trials. I think there'll be some subgroups who clearly should be treated with upfront therapy before surgery. There may very well be some subgroups who the outcomes will be identical, depending on what order you do it. So more to come, but we are so blessed that we do have much more in the way of active drugs than we did years ago. Although most of the regimens, for example, FOLFIRINOX regimen, which is one of the main regimens, that was not designed specifically for pancreatic cancer. I think it's important that we continue to study drugs, and particularly shout out has to go to PanCan for the Know Your Tumor initiative, which was initiated years ago. And the publications on that the data on that are very, very impressive. That is, if the patient has a tumor that contains an actionable mutation, and you can align the therapy with the mutation, the outcome is likely to be much better. And we have very good data along that line. Now, what we have to do is get to the point where 100% of patients' tumors are studied, and we can identify in 100% of patients their most optimal treatment, give them truly personalized treatment. We're not there yet.
What excites you about this field? And, when you look back on your career, What stands out the most to you?
So number one, we've made great progress. The 5-year overall survival rate's gone from 2 to 10%. By the same token, what a great field for young people to go into, because we just have a 10% overall 5-year survival rate. So there's still incredible room to move the needle, incredible opportunity. And there's many things in this field that deserve the attention of really smart young people. You alluded to one before: early detection. Another is better understanding the familial inheritance patterns that come with pancreatic cancer. Another would be identifying novel drugs, whether they're chemotherapeutics, immunologics, or other drugs, other classes of drugs, which will come along, no question. So there's many areas where people can clearly make a contribution. And then, surgery is challenging. I find it particularly gratifying to be able to do this surgery safely and help people. It's not that every operation is not important. It is not it has some challenge, but there's different gradations of that. So for young people, I'd love to encourage more and more young people to consider the treatment of pancreatic cancer, whether it's medical oncology, radiation oncology, immunotherapy, surgery, or even the palliative care domain, quality of life issues. There's a lot still that we need to accomplish to help our patients. But we've done a lot better. We're doing a lot better. And when I got in this field, most people that were diagnosed with pancreatic cancer, they considered it a death sentence. And there wasn't much hope. There were rare long-term survivors. I mean, there was even controversy back in the 80s about whether the Whipple operation should be done. There were a handful of people that thought it was madness to do that operation. And I think we've convinced people that that's not true anymore, and that there can be long-term survival. It can, with a good quality of life, return to essentially normal activities and have a lot to look forward to. So it is a great field for young folks.
Agreed. Being a survivor, I agree with all of that. So thank you. Thank you. I actually interviewed another survivor who cried when she said your name. A good cry, not a bad cry.
I try not to make people cry any longer.
No, but that meeting you, saved her life. So I get that. And, there are a lot of great surgeons out here. But I guess this particular interview means the world to me, because I consider you not only my surgeon, but my friend. And I'm so grateful to know you.
Well, ditto. And you're an incredible success story. And I must say,